you to the TTUISD Math Science Club webinar. Our webinar today is on nuclear medicine. I want to welcome all the attendees and the panelists that are joining us today. I just want to remind you that we do have events that take place monthly for the TTUISD Math Science Club, and we are glad to have those of you that are joining us today. We are recording this session so that it can be archived and placed on our website, so you may go back and view it at another time, as well as for those that might not be able to attend with us, they can view that after this event has completed. So I'd like to welcome you. For those of you that may be your first time to join us in this webinar, we do have club coordinators. I'd like to introduce to you our science coordinator is Sharon Story, our math coordinator is Pam Summers, and I'm the technologist Tracy Clanton-Smith. They're the ones that are putting together all of these events and hopefully finding some interesting stories and careers for you to follow with us. But again today, just a reminder about your media players. I believe most of you have probably had enough time to check that, but if you haven't, please make sure you go in and verify that you have the right media players for videos that will be played throughout the event today. Over to Pam so that she can talk to us about our sponsors through the STEM project.
I want to thank our sponsors, the TU University, their STEM research department, science, technology, engineering, and math. And we want to thank them for the funding that enables us to do this.
And we'll head over to our science coordinator, Sharon Story, so that she can give us a little bit of an introduction to our subject today of nuclear medicine.
We're excited today to have with us Terry Cannon. Terry Cannon is a nuclear med tech here at Lakeside Laboratories. She's a nuclear med tech and has been one for about 9 years. And so she's going to help us and go through the presentation as we proceed. You're looking at a slide here that shows a spinal column, and I'm going to let Terry explain just a little bit about the colored areas that you're seeing.
Areas are where there's something going on in the bones where it takes up more of the radioisotopes that we use to do these studies with. So that could be due to a fracture, it could be from arthritis, osteoarthritis, infection, a variety of things that could be going on in the bones.
Nuclear medicine is relatively a new career, and what you're looking at also, you see the purple and bright white area in the colored slides. Those are areas that the doctor would look at with extreme curiosity, because Terry has told us those are the areas that either it is infected or you're looking at osteoarthritis, maybe even a cancer that has metastasized to the bone. It's the same view, except we're looking at just a little bit on a different angle. And nuclear medicine is that they use radioactive nucleotides. So, your nucleotides are going to be specific for the area that they're wanting them to go to. If you look at a thyroid, then we're going to use iodine 237. If we're looking at bones, what do we use for bones, Terry?
It's called HTP, technetium HTP.
And it's radioactive also. One of the things that the nuclear med tech has to do is they have to monitor the patient when they inject them with these nucleotides. They don't want to be around little kids whenever you're radioactive. In the next slide, we're looking at a pharmaceutical, radiopharmaceuticals. These are patients, or these are people who will go through and they'll monitor the organs, or they'll monitor the radioactive isotope. Also, if you're interested in this area, a radiopharmaceutical person or pharmacologist is a new profession. It is also a very lucrative profession, so it would be something that you wanted to look at. They take the iodine that you would use for a thyroid scan, make it radioactive, and then they purify it down, and then they send it to the nuclear med tech so that she can administer the radioactive isotope to their patient. Abnormal areas are they going to show up in high and low concentrations because that's where your radioactive isotope is going to go. You have two major areas for your new nuclear medicine technology. One is the nuclear cardiology, and the other one is a PET scan. Sarah, you've worked PET scan, and so tell us a little bit, what is the difference between just what you would do as a nuclear medicine technologist and what you do as a PET scan technician?
On the PET scans, the isotope that's used there looks at the molecular level of the body, so it's is finite area that can be looked at, so it's much more detailed than what you get with regular nuclear medicine.
Okay, just a regular PET scan doesn't use the radioactive isotopes, correct?
No, it does.
It does. So anytime you have a PET scan, you're using the medicine, the radioactive isotopes?
Yes, I use fluorine-18 to do PET scans with.
Okay. So it's for every area, do they always use fluorine-18?
Yes.
So it is something that is common for PET scan technicians. Also, what are the safety precautions that a nuclear medicine or a PET scan technician would have to take in order to work with these isotopes?
They teach us to work with time, distance, and shielding, so that time talks about nuclides decay depending on what type of chemical they're used that they're made with. Shielding is you want to have a lead shield in front of you, and distance is normally considered 3 feet away from a patient or from the isotope. Then you're not going to have any contamination to yourself or exposure to the radiation.
Anything that is monitored?
Yes, we use badges, and they call them thyroid badges. We attach them to the top of our shirts or tops, whatever we have on, and then those are sent into a company that can measure the radiation exposure on those every 60 days. We don't safely, then we don't get to work.
I do if you had overexposure of radioisotopes.
Hospital or wherever you worked would send you home, and you wouldn't work for a period of time, depending on what your levels were. So
until the level was out of your body.
Mm-hmm.
What would happen if you have an overexposure over and over and over? What would the hospital do? What damages would be done to your body?
Well, the hospital would probably terminate you because you're not working safely. You're not practicing what you've been taught, so that you're protected, and then your patients or other employees around you are protected also. As far as the effect on the body, there's different things that could happen. You could have enough exposure that you could be a cancer candidate. It affects your thyroid the way it works, so it would cause you to either be a hyperthyroid person or a hypothyroid person. So there's a variety of health issues that you could be faced with.
Have you had a major spill?
Thank goodness.
Okay. What will happen if you have a major spill? And by major spill, I mean the radioactive isotope comes in a container that is lead.
Level.
Thank you. It's filled by lead, so that keeps it on the inside. So if you have a major exposure, that isotope would be out in the room, so the other, not doing the job that it was doing, and it would just be in the environment.
Yes.
So how would you clean that up?
Most of our isotopes are liquid, and so we've got some we use the radioactive washes. So you wash those. You take absorbent pad and put it over it, and we use a Geiger counter to see how much contamination that we had there. Depending on what the isotope was, how quickly it's going to decay, we might have a room that we're not going to be able to use for days or longer, depending on the isotope that we use.
Okay. Know that when you have a thyroid patient and you inject a thyroid patient, they stay in the hospital for a period of time while you're scanning them. Okay, let me ask you this. What happens to their family? Is their family allowed to visit them while they're in the hospital having that scan done?
No, not if they're having large dose. For thyroid patients that have thyroid cancer, the surgeon will remove the majority of the thyroid. They can't get all of it because it's attached to the vocal cord, so they don't want to risk damage that would be irreversible. And they'll give them a period of time, a couple of months possibly, for that to heal up, and then they would admit them again, and we would give them what we consider a large dose of isotope that would kill the remainder of the thyroid tissue that's left there. And so when that's done, we use a Geiger counter on the patient and monitor them at what we consider bedside, 6 foot, and across the room. And we've got a formula that we calculate to say how long a family member of any sort could stay, and that might be a total of 15 minutes a day until the isotope begins to decay and they're not radioactive.
Okay, I've heard you talk about this room as being a hot room. By the room, I understand that means that the room is contaminated with radioactivity. And what happens to the linens and everything that are in that hospital room?
Those stay in the room. Usually we'll leave them for a week to 10 days, go back with the Geiger counter and count, do the Geiger count, and see what the activity is. If the activity is low enough, by the guidelines that we have, then we could remove linens, the trash, leftover food, whatever, because nothing comes out of the room until it's at a level low enough that it can be removed in safely for everyone.
Not even leftover food that was in the room? It does not either?
It does not come out either, so it can be it cannot smell very nicely in there.
Okay. We have a question from one of our participants that says, how is it that these certain elements are attached to different areas? And it's my understanding, and correct me if I'm wrong, that the area that an isotope attaches to, it depends upon what the isotope itself is. Is that correct?
The isotope that we use for most studies is technetium, or we refer to it as TC99M. Everything in the body, including the bones, takes certain chemicals out of blood that it feeds off of. And so depending on the organ or bone that we're looking at, those chemicals are added to the technetium so it knows to go to the bone or to go to the heart, and that's the only organ that we'll see in the study. We won't see everything.
Okay. Like the picture that we're looking at now, y'all need to realize that there are 18 million nuclear medicine diagnoses and therapeutical procedures that are performed in the United States every year. So this is a profession that is a very lucrative profession, and a profession that they're definitely looking for people, because it is relatively new. It has not been around but for about the last 18 years. So the slide that we're looking at now, if you are a radiologist, and radiologists do interpret your procedures, what organ are you specifically looking at there?
You're looking at the lungs.
With the lungs. Mm-hmm. What can you tell, why is it that the lung on the left-hand side, why is it that that lung looks like there is an area that is missing?
Because that's where the heart sits.
And so the heart take up the radioactivity, or is it just a shadow?
It's a shadow. It's blocking it. We don't see all of that part of the lung because of the heart.
So anatomy and physiology is something that is very important to the nuclear med technician. Why is that true?
You have to know the body parts, the organs, tissues. You've got to know about your blood vessels, just everything on the inside of your body. You have to know where it's at and pretty much what its function is, and how it goes together and makes your body work.
So it would be fair to say that if the nuclear medicine technician was not competent and was not in their job correctly, then the radiologist would not be able to interpret the x-rays or the procedure because you did not do your job correctly.
That's correct.
So you're a very important part of the team that is healing that person.
So yes.
Okay, we're looking at a common image here, and you can see they're looking at the blood to the heart, the nucleotide, and all of that, the evacuation of the heart. Because what I'm going to interpret in this X-ray is whether or not the heart or lungs are evacuating all of the blood supply at a correct fraction, so that when the heart beats, it's not losing part of the blood in the heart, so that there's something wrong with the valves. So valves are one of the important things that they do with nuclear medicine X-rays.
That's correct.
Okay. Our next one shows a thyroid. Tell us a little bit about the thyroid. Why is it, first of all, it's butterfly shaped. You can see the middle, and then the little two wings on the side. Why is it that one lobe is larger than the other?
That's just how we were designed.
Every is that?
Everyone is like that. Usually the right lobe, and that's what each of those wings are called, or lobes, is larger than the left lobe.
What about the pink stuff in the middle? What is that telling you?
That tells you that there is more activity going on with the thyroid. It's absorbing more of the isotope that we gave them.
As our nuclear med-tech interpreted it so well, this scan did show that it was absorbing more than possible and that it's probably Graves' disease or it's Homer's disease, and this is something that the X-ray technician now gives, or the nuclear med technician would now give to the radiologist, the radiologist would give to the surgeon, and this person is probably looking at having part of their thyroid removed.
That's possible. Or the other option is you give them a designated dose of I-131, which is something that's radiated, so that it will kill out part or all of the thyroid.
Video we're going to watch now, and it's going to introduce you a little bit to nuclear, and then we're going to come back, and Terry has graciously brought us some of the studies that she has done recently, and we'll let her talk about those in just a few minutes.
Just a couple of minutes here. We'll wait for a very short time for the video to load. It looks like we have everyone has downloaded that video except for maybe one in our statistics showing. So just hang on. I want to give another minute or so, and then we'll start the video. All right, we're going to go ahead and get started with the video, and either you can watch it through our webinar event, or if you have it running a browser in a separate browser window, you might want to view that way as well. I just want to make sure we had plenty of time for download to take place for all our attendees.
Understanding nuclear medicine. What is nuclear medicine?
Well, medicine is a branch of medicine and medical imaging that uses a small amount of what we call radiotracers or radiopharmaceuticals to diagnose disease and to treat disease.
How does nuclear medicine differ from other types of radiology?
It really differs from other modalities that you may know about, like CT or MRI, which are those studies are clinically based. They look at anatomy, structure. Medicine really looks at physiology of the body, of all the organ systems. Follow the physiological processes as they occur in a living human, using these radiopharmaceuticals and through use of appropriate imaging systems.
Called nuclear medicine.
Well, it is called nuclear medicine because, as I said, we use small amount of radioactive material, which are based on the nuclear.
We have kind of talked about what a nuclear medtech does. Let's talk a little bit about the schooling and a little bit with our speaker. She's a Covenant Medical nuclear med technician. She's been there for 9 years. And she came to nuclear medicine in kind of in a roundabout way. She's a great example that you have to be a life learner. She went to school when she was in her 40s, very early 40s, but she has been doing it since then. And tell us a little bit, Terry, about where you went to school and what you had to study in order to get your degree.
I attended Emma College, its degree in Allied Health. There are only 5 colleges in Texas that teach nuclear medicine. Those are 2 associate's degrees, and 2 of them are 4-year degrees. In the classes, you're required to take chemistry, physics, biochemistry, one of your basics, A&P 1 and 2.
Algebra 1,
yeah,
history, all of your basics.
Your prereqs.
So basically your first year, if you're going to an allied health program, is just going to be basics like English, history?
No, you've already got those taken and been out of the way before you can be accepted into a program.
The program itself is 2 years.
The program itself is 2 years.
So really it's more than just a 2-year program because you have to have your basics before you go to the allied health program.
That's correct.
Okay. And where are the other schools that are 4-year college degrees, or where are the other locations in Texas?
The 2 that are 4-year degrees are Better College of Medicine in Houston, and then Incarnate Ward in San Antonio.
Your other 2-year program?
Houston Community College in Houston and Galveston College in Galveston that was for the University of Houston in Galveston.
Is there any way that you can just have on-the-job training anymore to be a nuclear med technician?
You cannot. Earlier, probably 10-plus years ago, you could grandfather, but then you still have to pass your board to be certified. And if you're not certified, you can work in outpatient facilities, but any hospital facility, you're not allowed to work if you're not licensed.
Talking about certification, so kind of tell us what you have to do in order to be certified.
To be certified, you've just got to be able to pass the state registry. From experience, that I could have been self-taught and able to pass the boards.
And we talked a little bit about a radiologist. A radiologist is an MD, so he's gone through medical school, or she, and they specialize another 2 to 3 years on just how to read X-rays. And they read not only nuclear med studies, but they also read all the other X-rays. So theirs is a medical MD track. Okay, so he has brought us 4 studies that we want to look at today. So we're going to look at the next slide and let her explain to you what you're looking at.
This is a patient that has melanoma that's on the scalp. So he's injected on the site where the melanoma is, and then we take pictures waiting for that to drain into the lymph nodes so that the doctor can then biopsy those lymph nodes in surgery to see if they're benign or malignant, and then that will determine the patient's course of treatment after that.
Okay, this one already has this patient already had surgery to have that melanoma growth taken off?
Yes.
Okay.
Majority of the time that's done first, and then it's determined that was malignant, and then they go back to check lymph nodes to make sure it hasn't spread or metastasized into the body somewhere else.
The radioactive site that we're looking at is the white dot. Like on the first image, it's right above the X there in the 6X. Is that correct?
That's correct.
And so where all our radioactive isotope is going. What is this TP? What did you say?
It's technetium, TC9M. That is, that name is filtered sulfur colloid is what we use for doing lymph node studies.
So they're using sulfur because sulfur is very heavy, and so it's not going to travel very far whenever they inject it. It will travel primarily to your lymph node side.
That's correct.
Okay. Idea what they would do, how much of the lymph nodes, like, can you look at this x-ray and can you tell us, was there lymph node involvement in this one?
Yes, there's lymph node involvement. Look on the second row, the second and third picture. It would be area about where the center of the ear would be, or towards the back of where the center of the ear is in there. So the surgeon would make an incision in there and get you so that the pathologist can check that to see if it's malignant or benign tissue.
Okay, and is that as far as it's going to travel, there's more involvement past the center of that ear?
When it gets the patient to surgery, as more time passes, it's possible that the isotope can travel, and what the surgeon will do is use a Geiger counter there to detect where the radiation is if it goes any further than the one site that we see on those pictures. But it's possible. The first lymph node that it goes to is called the sentinel node, which just means it's first line. They'll probably biopsy, if they were to see 2 or 3 lymph nodes show up on the pictures, they biopsy all of them. If the first is benign, there's no way that the second or third could be malignant. So they're certain once they hit one that's benign, from that point on, there can't be any malignant lymph nodes past that point.
And so lymph nodes always drain in a specific order.
They do.
They do. Okay. Let's next study. What are we looking at here?
This is a patient that's had thyroid cancer. She's had the majority of the thyroid removed. The doctors won't remove all of it because it is so close to the vocal cords that they don't risk damaging the vocal cords, because most of the time that damage is irreversible. So then they take an I-131 capsule that the thyroid feeds off of iodine, so it's radiated, and so you'll see how much thyroid tissue is still left if you see a bright spot, as much as what we're seeing right there. If we didn't see much at all, you would know that the majority of it was removed in surgery, but this patient has a considerable amount of thyroid tissue left.
It's like a star radiate from her throat.
Because there's such radiation in that one spot.
Okay. What did they do? What was your standard, or what happened from this point on?
She was readmitted to the hospital and given a very large dose of I-131 to kill out the remainder of that thyroid tissue that's there.
And how long was her hospital stay?
The hospital stays will last most of the time 2 to 4 days. The room isolated from other rooms around. The isotopes have a very high level in them, and so a Geiger counter is used along with a formula to see how radiation is in the room, and we could determine how time family or visitors could spend in the room. And with the patient, like the first day of dosing would be maybe 10 to 15 minutes that they could be in the room. The ice decay at different time frames, depending on what type of an isotope it is. One decays every 8 days in half, and so we talk half-lives, how long it takes for that to decay and be pretty much out of the system. And so I have 8 days. Technetium is what we use for the majority of our other studies, and it's 6 hours, so it's pretty fast.
So iodine-131 really has a longer half-life than the others. Okay, so you said she was in the hospital for approximately 3 days. Then her room was still hot?
Yes.
Okay, so how long was her room sealed up?
Her room will be sealed up for 8 days minimum, and then we'll go and use a Geiger counter to detect how much radiation is left in the room. And if it's low enough, then we can clean out linens and trash and leftover foods and whatever's left in the room.
So and do they wash the room down then with a specific solution?
They do, and also the room's prepared before the patient goes in with absorbent pads. Floor, they're taped to the floor. On the faucets and handles in the bathroom, on the sink, the toilet, the shower, that's all wrapped with saran wrap. And like the lid to the toilet and all that stuff. Anything that the patient would be using or that would end up with fluids on it is wrapped. And so once the room's decayed, then all of that stuff is cleaned out also. So that's one way to keep contamination or exposure to the radiation. That would be through if the patient coughed or sneezed or they got sick and they threw up. All of their body fluids are going to be radioactive.
And so it's quite expensive to have this done.
Yes.
Because to go in and there's such a procedure before and after, and the disposal of all the linens and everything. So that enters into the cost of the procedure. Okay, once this is done, what is the success rate that the thyroid is killed and we've killed off all of the cancer-causing tissues?
Most patients have a very high successful rate at just some treatment. Occasionally it doesn't cut out, and so they may come back in a year or two and have the same procedure done again. The majority of the patients, it just takes one treatment and all the thyroid tissue is killed out. And the patient is put on thyroid medication because it's a hormone, and thyroid controls every other system in the body. And so you have to have thyroid hormone. You can without it for a while, but you can't live without it.
So thyroid cancer is very treatable.
It is very treatable.
And then the patient to replace that hormone.
That's correct.
So if we want to have cancer, that's the type of cancer we want to have.
That would probably be my pick if I had to have one.
Okay. Let's go next slide. Okay, what are we looking at here?
This is a patient, a female that has breast cancer, and so we've done the injections like we did on the slide or 2 slides back. That was the that had him on his head, and this injection's done in the breast, and then we wait to see where it moves to. And the same thing, the surgeon will go in using a Geiger counter and our pictures to show where the lymph nodes are, and then those will be biopsied in surgery.
And nodes, how many lymph nodes are you showing on this picture? Is it just one, or is there more than one?
There's just one. It's
inside?
Part of those are the injection sites.
Okay, how many places do they inject on a breast around the tumor that they remove?
4 times.
They go
4 injections.
Top, bottom.
Now do it in the quadrants, so it's like a clock from 12 to 3, 3 to 6. Quadrant that tumor sits in, and that's the quadrant that the injections will be made in.
Okay, and so we only have one, and again, the first node would be called, that it drains to would be called the sentinel node.
That's correct.
Okay, and so then this would be a patient that was not having their total breast removed, but was having a lumpectomy.
No, it would be for any type that was diagnosed with breast cancer.
Okay, so the patient then have the choice after this is done to go back and say, I want just that area removed, or would go ahead and they're taking off the breast and just make sure it's not draining to the other lymph system outside of the breast.
If this procedure is done to see if the cancer is in the lymph nodes, and whatever lymph nodes do show from the pathology report that's done during surgery, those lymph nodes will be removed.
Okay.
So it doesn't matter if the patient's chosen a lumpectomy or a mastectomy, the lymph nodes have got to go if they're malignant.
Okay. Why do lymph nodes have to go if they're malignant?
Because that will continue to spread through the body, and it's called metastases. And
you get the lymph node, then your chances of metastases is decreased.
That's
okay.
Right.
All right. Let's look at the next slide.
This is a hepatobiliary scan, or an easier way to say it is a gallbladder scan. This is to see, number one, if the patient has obstruction to or from.
I've done one more. They're done in time frames.
They're in time frames.
Okay. So tell us exactly. Ooh, there's the little hanging down part. Is that the gallbladder?
That's the gallbladder.
Ooh. Okay.
That's it.
And so we're looking at it in the first one.
The first we see liver, and then we're beginning to see the hepatic that's beginning to show there. And we just give it time for this to mobilize through the liver, and we want to see the gallbladder, the common bile duct, and the small bowel.
So in the fifth slide, you're looking at the beginning of the gallbladder.
That is a lateral picture taken from the right side, and that is the gallbladder that we're seeing really top of where the really bright spot is, and what's hanging below that is the valve.
Okay, and what are you looking for when you're looking at the gallbladder? Looking for growth or for stones? Or
for medicine, we can't see stones. Those are seen with either ultrasound or CAT scan. Basically, first we want to see if there's blockage to or from the gallbladder, the common bile duct, or the small bowel. And then once we determine there's not blockage, then the gallbladder is stimulated either by use of a drug or a fatty drink, like an Ensure, that make it contract and squeeze, which is what its job is, and it can determine if the gallbladder is functioning properly or not.
and over what time frame were the pictures taken?
This slide here, the pictures are at probably at about an hour.
Give them the drink. Pardon me. You give them the drink, they wait an hour, and then you take the first round of pictures.
With the red slide, and we begin to pictures, and we wait to see the gallbladder, the common bile duct, and the small bowel visualized. When then we set them up, and we give them the drink to drink, and where we determine how well the gallbladder is functioning.
And this is the second set of slides. At what time frame were these taken?
These are taken once we've had the patient drink the drink to stimulate the gallbladder. Then we have them lie back down, and we take pictures in minute increments for 30 minutes.
So see exactly where it's moving.
We can sense the gallbladder's contracting and getting smaller.
Okay, what can you tell us about this case study? Was there a problem?
This case study was normal gallbladder. It's called ejection fraction to say how well the gallbladder is functioning.
And it was perfectly normal, and the symptoms they were having was caused by something else.
By something else.
Okay. So now they don't have to have their gallbladder removed.
That's correct.
Go back to what is this?
This is a lung scan on a patient. Most scans are done to see if a patient has pulmonary embolism or blood clot. It's the same thing. More people know it as a blood clot than a pulmonary embolism, but that's what it's called.
Did this patient have one?
No, they did not.
Okay. If they would have one, what would it have looked like?
We had a difference in the lungs from picture to picture. There could be a segment that looked abnormal, but as long as that segment showed the same in each picture, then we know that it's not. So,
and so the normal lung.
This one was a normal lung scan.
It is very important to have nuclear med studies done, not only to see the problems that you have, but to make sure that they don't treat something that is not a problem.
That's correct.
Okay. I want to thank Terry for being here today, and she has answered a lot of our questions. I really understand nuclear med a lot more now, and some of the procedures that maybe my parents are going to have done a little later on. And some of the things that you want to explore, we're going to let Pam talk about those for just a minute.
Well, I didn't participate much today. I was really listening and learning, because not being the science person I know that I should be, I've learned a lot today, and I hope that you all have too. When we go through our questions, what is the educational background necessary for this occupation or field of study? Again, these are some things that you may want to go in and investigate. If you have questions, just use the blog and let us know. What is the coursework necessary for success in this occupation? Well, we didn't say much about math, but we know that math is in there. It's going to be a prerequisite, so it's going to be there. We know that there's going to be a whole lot of science, including anatomy and physiology, which would not be my favorite. What is job outlook for nuclear medicine technologists for the next several years? It looks to me like this might be a very interesting career path to investigate. It's important that nuclear medical technologists understand the half-life of radioactivity isotopes. That's a good one.
Even though half-life you have to know exactly how long your room's going to be hot, how long your patient's going to be hot, because we don't want to expose anybody that has a problem to something that caused them to have cancer later on. And Pam's wrong, because there's your math right there. You would be able to calculate your half-life of all isotopes. You can't do that with the good old calculator and algebra.
Where do nuclear medical technologists work? What are the precautions needed for this field? And what are the safety precautions that are in place only protecting the patient? As Ray told us today, there's a lot to the safety precautions, and you want to make sure that the nuclear tech is taken care of and that they're all practicing the safety protocol that's available and in place. We all have enjoyed today's webinar. Remember again that if you have questions, there's a follow-up blog available to you. And on behalf of all of us here, including Tracy, Sharon, and I, we want to wish you all a very Merry Christmas and hope you all have really wonderful holidays.
And to give you a little preview about our upcoming webinars and what's coming up in January, March, and April, our next webinar will be Tuesday, January 24th. Right now we have it set at noon Central Standard Time, and it's going to be covering Wind Science and Engineering Research Center, as well as some school chasing. So we are looking forward to putting that event together for you, and we hope that those of you that have joined us, you spread word to your friends and others that might be interested in the January webinar. And we are so happy to have you today, and we look forward to joining us in the future for future events. Again, for all of us here, we want to wish you a very Merry Christmas, a wonderful holiday, and a Happy New Year.